Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, let's jump right into the pharmacology of hypertension. If you're in the medical field, you already know these are some of the most common drugs out there, period. And look, getting a handle on them isn't just about acing your exams. It's about truly understanding how these drugs and our bodies work together. So, let's get into it. Okay, so here's how we're going to break this down. First, we'll nail down what hypertension actually is. Then, we'll check out how the body controls blood pressure on its own. Because once you get that, it makes total sense how the drugs work. They're basically hacking those systems, right? We'll look at the ones that target RAS, the sympathetic nervous system, and fluid volume. And then we'll pull it all together and see how this plays out in the real world when you're making clinical decisions. So, what are we even talking about when we say hypertension? Well, at its heart, it's just sustained high blood pressure. The magic number we're usually looking at is 140/90. You've probably heard it called the silent killer, and for good reason. It's the most common cardiovascular disease, and getting a lid on it is it's absolutely crucial to prevent really terrible things like strokes and heart attacks. This table here really shows you the different stages. We all know that ideal spot, right? Less than 120/80. But you can see how, as those numbers start to climb, you move into pre-hypertension, then stage 1, and on to stage 2. And the key thing to realize is these aren't just random labels. No, they're thresholds that tell us, okay, it's time to act, and they guide how aggressive we need to be with treatment. All right, before we even think about the drugs, we've got to talk about the body's own control systems. This is a huge principle in pharmacology, really. These drugs aren't creating some new magic process. Nope, they're just tweaking the systems the body already has in place. So let's take a look at what those are. So think about it like this. Your body has a two-speed system for controlling blood pressure. You've got your fast-acting crew, the baroreceptors and sympathetic nervous system. They handle the immediate stuff, like when you stand up too fast. Then you have the long-term manager, and that's the kidneys. Over days, even weeks, they're carefully managing your blood volume, and the main tool they use is something called the renin-angiotensin-aldosterone system. You'll hear it called RAS. And this diagram really lays out that long-term system perfectly. So when your kidneys feel that blood pressure is dropping, they shoot out this enzyme called renin. This starts a whole chain reaction. It turns angiotensinogen into angiotensin 1, which then gets converted into this super powerful molecule, angiotensin 2. Now, angiotensin 2 is the real player here. It does two big things. It physically squeezes your blood vessels, and it tells your adrenal glands to release aldosterone, which makes you hang on to salt and water. Both of those things, they drive your blood pressure right back up. Definitely keep this pathway in mind because we're about to mess with it. Which, leads to a pretty logical question, right? If this RAAS pathway is so good at jockeying up blood pressure, what happens if we block it with a drug? Well, that's exactly the idea behind two of the biggest classes of drugs we have, ACE inhibitors and angiotensin receptor blockers, or ARBs for short. Okay, let's start with the classic example, the ACE inhibitors. We're talking about drugs like lisinopril or enalapril. The name tells you exactly what they do. They inhibit the angiotensin-converting enzyme. So you block that enzyme, you can't make angiotensin 2. That means your blood vessels relax and you get less aldosterone. Simple enough? But, and this is the really key part, the ACE enzyme also gets rid of a substance called bradykinin, which is a natural vasodilator. So when you block ACE, you get a buildup of bradykinin, which helps lower blood pressure even more. This 2-for-1 mechanism is a huge deal, and it's definitely something you'll see on exams. And what's really cool is how the mechanism explains the side effects perfectly. Remember that extra bradykinin we just talked about? Well, that's the culprit behind the two classic side effects that always come up. That annoying dry cough that just won't quit, and the much scarier one, angioedema. And think about it. If you block aldosterone, which normally gets rid of potassium, it makes sense that you could end up with too much potassium, right? Hyperkalemia. And last but not least, a super important safety point, you absolutely cannot use these in pregnancy. Total no-go. So what do you do if your patient gets that terrible cough from an ACE inhibitor? Well, that's where the ARBs come into play, drugs like losartan. They block the same RAS pathway, but they do it a little differently. Instead of blocking the enzyme, they block the receptor where angiotensin 2 actually does its work. And here's the crucial difference. ARBs leave bradykinin completely alone. So no bradykinin buildup means no cough and a way lower risk of angioedema. This makes them a fantastic alternative if someone can't handle an ACE inhibitor.
Okay, let's switch gears to some drug interactions you really, really need to know. First, mixing an ACE inhibitor with NSAIDs, that can be a real double hit on the kidneys. And since we know ACEs can make you retain potassium, giving someone potassium supplements on top of that is just, you're asking for trouble. And this last one is a huge red flag. You never, ever combine an ACE inhibitor with Entresto. The risk of a life-threatening angioedema is just way too high.
All right, so we've tackled the RAS system. Now let's move away from the kidneys and focus on the heart and blood vessels. We're going to look at how we can target the sympathetic nervous system with a class of drugs I'm sure you've all heard of, beta blockers. So what's the main job of a beta blocker? Basically, to chill the heart out, slow it down, and make it pump less forcefully. But the most important thing to get here is that not all beta blockers are the same. Take propranolol, the classic non-selective one. It hits beta-1 receptors in the heart, sure, but it also hits beta-2 receptors in the lungs. And that's exactly why it's a huge problem for anyone with asthma. A much better pick for them would be something cardioselective, like atenolol, which sticks mostly to the heart's beta-1 receptors. And then you've got these other guys, like carvedilol and labetalol, that do even more. They also block alpha-1 receptors, which gives them this extra vasodilation effect. Okay, our next couple of drug classes are super straightforward. One gets rid of extra fluid, and the other one directly relaxes your blood vessels. So let's dive into diuretics and calcium channel blockers. So let's talk about one of the oldest, most trusted tools we have, diuretics, specifically thiazides, like hydrochlorothiazide. Their game plan is beautifully simple. They tell the kidneys to get rid of more sodium. And, as you know, wherever sodium goes, water is sure to follow. So you lower your blood volume, and that brings down your blood pressure. But whenever you're messing with the kidneys like this, you've got to watch out for the fallout. We're talking about electrolyte problems like low potassium and even metabolic changes like high uric acid, which could unfortunately set off a nasty gout attack. Calcium channel blockers are also pretty cool. They work by blocking the tiny channels that let calcium into the smooth muscle cells of your arteries. And here's the thing. Those muscle cells need calcium to contract. So if you block the calcium, the muscles can't squeeze, and the arteries just relax and open up. That's vasodilation, and that directly lowers the resistance in your vessels and brings down your blood pressure. So, as you'd probably guess, the side effects come right from all that vasodilation. We're talking headaches, flushing, maybe some swollen ankles. But, and this is a super important point for exams, you have to know the difference between the two types. You've got the dihydropyridines, like nifedipine. Think of them as vascular specialists. They're so good at relaxing blood vessels that sometimes the heart tries to compensate by speeding up. That's reflex tachycardia. Then you have the non-dihydropyridines, like verapamil and deltiazem. They're different. They work on the blood vessels, yes, but they also work directly on the heart, slowing it down. So with them, the big thing to watch out for is the heart going too slow, bradycardia, or even heart block. Okay, so we've gone through the nuts and bolts of all the major drug classes. But now comes the most important part, right? Putting it all together. How do we take all this information and actually use it for a real person sitting in front of us? How do we make the right call? And really, that is the question in clinical practice. The answer is never just which drug is strongest. No, it's about tailoring the treatment to that specific person, their age, their ethnicity, and what other health issues they might have going on. This flowchart is a great place to start. It's often called the ACD rule. Basically, for a patient under 55, you'll usually start with an A drug, that's an ACE inhibitor or an ARB. But for patients 55 and over, or for patients of African or Caribbean descent, you'd start with a C, a calcium channel blocker, or a D, a diuretic. And if that first drug doesn't get the job done, you start adding on other drugs in a really logical step-by-step way. Now, this slide right here is pure gold for exams and for the real world. A lot of the time, the right drug choice comes down to what other conditions the patient has. For example, if your patient has diabetes, an ACE inhibitor is a great choice because it doesn't just lower blood pressure, it also protects their kidneys. On the flip side, you would never give a beta blocker to someone with asthma. That's a classic no-no. And for pregnancy, ACEs and ARBs are completely off the table. Instead, you'd use safer drugs like methyldopa or labetalol. Really getting these specific situations down it's fundamental to prescribing safely. And this quote really sums it all up. In someone with chronic hypertension, their body's control systems have basically reset themselves to a new, higher normal. Our whole strategy with these drugs is to step in and intelligently mess with those pathways to bring that set point back down where it belongs. And it's wild to think about, but for more than 90% of patients, we're treating something called essential hypertension. That's just a fancy way of saying we don't know the exact cause. And that's exactly why we focus so much on managing these big physiological systems, like RAS and the sympathetic nervous system. Because no matter what starts the problem, these systems are the final pathways that are actually controlling the blood pressure.
So you can see how far we've come, right? We've gone from a one-size-fits-all mindset to this much smarter approach based on the individual patient. And that leaves us with a big forward-looking question. What's next? What's the next big leap? I mean, could we get to a point where we use someone's DNA to pick the perfect blood pressure medication just for them? A true era of personalized medicine. It's something to think about.